Okay, here we go with suicide and non-suicidal self-injury. This is on your test. Questions are already written, so be sure that you watch this whole thing. The first thing, suicide is intentional act of killing oneself by any means. This is the 10th leading cause of death. Fourth leading cause of death among children, 10 to 14 years of age. And then you have your third, fourth, and eighth leading cause for the other ones. Make sure you just refresh box 25-1, 482 suicide facts. Just go ahead and just read through those. Psychiatric, there's risk factors, psychiatric disorders, alcohol or substance abuse disorders, male gender, so males commit suicide 4 times more often than females. Increasing age, males peak after 45, women after 55, and then the rest of your risk factors there. I'm not actually asking you guys anything about that, but there just is different risk factors, and in the classroom scenario, we would go in depth into each one of these. Your biological and psychosocial factors. So suicidal behavior tends to run in families. Low serotonin levels are related to depressed mood. So, and we will talk more about that sort of thing with more chapters, especially once we get into the SSRIs, which are for depression. Freud said this was aggression turned inward. Menninger said that there's the wish to kill, wish to be killed, wish to die. Aaron Beck, central emotional factor is hopelessness. It's all or nothing thinking. Remember we learned about that with cognitive disorders, that it's either always or never. And recent theories have said a combination of suicidal fantasies and significant loss, as well as there can be copycat suicide. You'll sometimes see in families, and I think we're going to get there, there's an increased risk in family members if another family member has committed suicide. Cultural factors. So the protective factors that some cultures have are listed here. So African Americans tend to have big roles in the extended families and tend to be religious. So both of those are considered protective measures, protective factors. Hispanic Americans, Roman Catholic religion, and importance again of extended family. Asian Americans, adherence to religions that tend to emphasize interdependence between the individual and society. So that society and the individual are more of a one that we all depend, or that they depend on all of it. Other things to be aware of is that white non-Hispanics have the highest number of death by suicide, and now something newer in our generation, or our current culture, society, as suicide bombers. That this is a new thing that we're looking at with the different terrorist attacks and things of that nature. That we have these massive suicides and people kill themselves in order to kill many. Societal factors. So there's different things that we have going on, and these are very interesting to know. Oregon has that Death with Dignity Act. It's of 1990, since 1994. Terminally ill patients allowed physician assistant suicide. So many of you may have been aware of the story not too long ago of the younger lady suffering from incurable brain cancer, and she moved to Oregon and was in the big movement for the Death with Dignity Act. In Washington State, physicians can prescribe lethal medication. In the Netherlands, non-terminal cases of lasting and unbearable suffering. Belgium, non-terminal cases when suffering is constant and cannot be alleviated. And Switzerland has allowed assisted suicide in the legality form since 1918. So this is just in comparison. The majority of the states, however, in the United States, does not allow for assisted suicide. So application of the nursing process, our assessments. So these are important verbal and nonverbal cues. So overt statements are basically just say exactly what the person is thinking. I can't take it anymore. Life isn't worth living. I wish I were dead. Everyone else would be better if I died. But then you have your covert statements, which means there's like a concealed message of suicide within it. And so if somebody says, it's okay now, soon everything will be fine, things will never work out, I won't be a problem much longer, or how can I give my body to medical science? Other things that you will see is people giving away belongings when they have been suicidal or having suicidal ideation, and then they start to give away their possessions. That can also be a cue that somebody is contemplating suicide and actually is likely to be thinking about truly moving forward with the plan. Continued. So another very important thing is the lethality of the suicide plan. So you want to ask yourself, is there a specific plan with details? How lethal is the proposed method? And is there access to the planned method? So we want to find out if they're talking about it, if they have access to whatever the planned method is, how lethal that plan would be, which we're going to talk about in a second, and what are the specific plans with details. So when we are talking with patients and we ask them if they've been having suicidal thoughts or suicidal ideation, we then want to ask them if they have a plan. Many times they do not, many times they do. So it just depends on the purpose or on the person. So we want to continue to ask more questions so we can find out the details, how lethal it is, and if there's access to it. So we have hard and soft methods. Hard methods include using a gun, jumping off a high place, hanging, poisoning by carbon monoxide, or staging a car crash. And soft methods include slashing wrist, inhaling natural gas, and ingesting pills. So our soft methods typically are more of a cry for help. Hard methods are obviously somebody who is much more serious and truly is wanting to kill themselves. So this is the SAD person scale. This is the scale that is used to assess for suicide potential. Remember, SAD persons. These are the 10 major risk factors. So sex, if they're male, they get a point. And so there's a point for each one of these. So you see age 25 to 44 or 65 and older. Depression, a previous attempt, if they drink alcohol. Rational thinking loss. So social support's lacking or recent loss. So if they don't have a good social support or they've recently had a very close person die. An organized plan. No spouse, and some kind of sickness, illness. So they would get a point for each one of these. And so here is your SAD person scale and how you would add it up and what it would mean. So at your bottom, you have a score less than 2. This would be a discharge with outpatient psychiatric evaluation. A score of 3 to 6 we would consider to hospitalize or at least very close follow-up, and a score of 7 or greater is for sure going to have them hospitalized. Some more diagnosis. Risk for suicide would be your highest priority for somebody who is suicidal. The outcomes would be suicide, self-restraint, and then we have implementation. We're going to talk about these: primary, secondary, tertiary. They also will develop suicide contracts or a self-harm contract with these patients, that they'll actually sign and develop a contract that they will not harm themselves. And yes, it is just a piece of paper they're signing their name on, but for some reason, these contracts tend to be very helpful in the psychiatric setting because they are making, a contract with that healthcare provider. So your level of interventions, your primary includes activities that provide support, information, and education to prevent suicide. There's this QPR, question, persuade, refer, and then we do train the trainer with that sort of thing. But your primary, remember, we want to educate different things of how to cope, and so we just prevent that suicidal ideation altogether. Secondary would be treatment of actual suicide crises. So this is done in hospitals, jails, telephone hotlines. And then tertiary is interventions with a circle of survivors left by individuals who completed suicide to reduce the traumatic after effects. So it's very important, since the suicide rate increases for those who have experienced a loss from suicide. And we need to remember with this tertiary that the family members or the survivors, whomever it may be, of the person who committed suicide are now the patient. It is not the person who committed suicide that is the patient anymore. It is now the people who are left after the fact. So interventions, teamwork and safety. So if somebody's a suicidal risk, they would start on a 1-to-1. Then as they move through and become less suicidal, they'd go to every 15-minute to every 1-hour checks. Counseling, so the new no suicidal contract or no harm contract. That's what I was just talking about a second ago, that we have them sign this saying they won't harm themselves, and if they feel like they're going to, they're going to notify health teaching and health promotion. This is specifically done with community resources, case management, pharmacological interventions, so antidepressants, and remember we will check for these patients for cheeking because if they do not take the meds, they're at higher risk for becoming more suicidal. And then postvention for survivors of completed suicide. So again, remember the survivor is the patient, not the deceased. The surviving family may experience overwhelming guilt and shame. Family members are 4.5 times greater risk of suicide than in families where no suicide occurred. And then on page 493, there is a little section that's written by a mom about a daughter who committed suicide, and it's a pretty good read if you get an opportunity to read that. It's not that long. So non-suicidal self-injury, the prevalence, this begins between 10 and 15 years of age. The lifetime prevalence is 13 to 23% for adolescents that somebody will hurt themselves. So here we're definitely talking about cutting and things of that nature. Comorbidity, so see our first thing right on there is borderline personality disorder, which we just talked about, and how they typically tend to be cutters. They do self-harm. Anxiety, substance use disorder. So etiology, we have our biological factors, cultural factors, and societal factors. So the social phenomenon that, you know, if one person starts cutting, especially if we're thinking about teenage girls, maybe then more teenage girls are going to cut themselves as well. So which method of suicide has the highest lethality? Your choices would be cutting one's wrist, overdose of medication, or a self-inflicted gunshot. Those A and B are both soft methods, so your answer would be C because that is a hard method. And that's it, guys. So study, and we'll have our test on Monday, and I will see you all then. Have a good weekend.